ladies and gentlemen, a very warm welcome once again to 5 Minutes with eCancer. I'm Richard Sullivan, the Chairman of Trustees for eCancer and also Professor at King's College London and Guy's Cancer Centre. Well, it's a great pleasure to introduce another friend and member of the COVID-19 and Cancer Global Task Force to join us today. It's Professor Dr Yusuf. He's speaking to us today from the Shaukat Khanum Memorial Cancer Hospital and Research Centre, which is in Lahore in Pakistan. Asim, very warm welcome indeed to eCancer.
Thank you, Richard. A pleasure as always to see you.
Wonderful. And we're talking today about an absolutely fantastic paper that Asim and his colleagues, amongst many other papers, has produced over the COVID period. And I have it here, and it's called Cancer Hospital Stockpiles, Strategizing for an Efficient and Sufficient Inventory List for Essential Items. It's absolutely fantastic, published last year, October 2021, in the Journal of Global Oncology. But before I ask Asim a few questions about this particular paper, Asim, maybe you could tell us a little bit about the work you've been doing in Pakistan leading up to this publication during the pandemic.
Yes, and thank you for inviting me, Richard. I'd just like to acknowledge my two co-authors, Khwaja Shahryar Nasir and Hussain Qadri. Khwaja Shahryar, in fact, was the sort of driving force behind the paper. So we are a specialized tertiary care cancer hospital. We have a hospital in Lahore and a second one in Peshawar in the northwest part of the country. We see patients only with cancer, really, from within Pakistan mostly, but also from Afghanistan. At the start of the pandemic now, 2 years ago, our principal concern was how we were going to protect our patients and staff. All of the patients obviously all have cancer, all immunosuppressed on treatment, how we were going to protect them from COVID and obviously also provide a safe working space for our staff. And at that time, we were a couple of months behind the West in terms of the onset of the pandemic. And so we were seeing on our TVs every day, hospitals where PPE was running out, where oxygen was low. I think even in first world countries, hospitals were closing because of a lack of oxygen and so on. So those were the sorts of issues that were exercising our minds, if you like, at that time, amongst others. As it happened, the pandemic did not affect Pakistan as badly as we had feared, and as badly as some other countries in our neighborhood even. So we were fortunate in that respect. But even then, we did find in the first wave particularly that we came very close to running out of key items of PPE, running very short on oxygen. We never ran out, but we were close to it on a couple of occasions. And, you know, astronomical increases in prices of some lab reagents, some PPE in particular, and so forth. So those were the sorts of issues that led us to start thinking about how to stockpile, what we should stockpile. And later in the year, then that's what led us to start thinking about writing a paper, because we thought that others could learn from our experience too.
Well, that's a wonderful segue, because I mean, I think this is one of the most extraordinary issues about this paper, is that you're one of the few people to really looked at this issue of preparedness and stockpiling. And it's something, as you said, you know, a lot of people were talking about around the world, but there's been really very little hard data. First of all, what items are necessary during a pandemic to stockpile. And then secondly, something that really comes out in this paper is, of course, and you just mentioned it, is the cost escalation. I mean, some incredible increases in the individual unit costs of some of the items you had to purchase. Can you tell us a little bit more about your findings in depth?
Yes. So we decided that the principal things we had issues with were drugs, oxygen, personal protective equipment or PPE, lab reagents, and some contrast and other materials used in radiology investigations. So these were the 5 main areas that we looked at when we were sort of analyzing our data and deciding how to recommend to our institution, because that's how this essentially came up, was a plan to recommend to our institution what items of equipment and supplies we should consider stockpiling for future waves of the pandemic. What we did was that we took the prices that we had paid during the first wave, the peak period of the first wave, which in Pakistan was in June 2020. And we compared prices for each of these 5 main groups of items to the prices we had paid in June 2019 as a control period prior to the pandemic. And what we did was, where we found that there was an increase of at least 15% in cost, or where there had been supply issues, those were the items that we then decided to study further. at a greater length. So very quickly, we were able to see that radiology, for instance, contrast materials and so on, there was not really a problem with supply. Prices didn't go up that much, and so we didn't analyze that any further. Similarly, with lab reagents, there was some shortage on occasion, particularly to do with COVID PCR testing kits, and actually the supplies that you need as well, the swabs and the transport material for the viral transport material and so on. But because most of these were imported, and by the time, given the lead time for them to actually get into the country, they were expensive, and there was very little usable time left in their sort of time, their lifetime, if you like. So we decided that that probably wasn't something that we could really stockpile. So it wasn't just based on shortages, but also on the economics. It would have cost us too much to stockpile lab reagents, and they then had a relatively short useful life left before their expiry date. The items that we did decide to stockpile were personal protective equipment, where there were tremendous shortages because until the pandemic, most of this equipment was being imported into Pakistan. Actually, local manufacturers rose to the challenge, and within a few months, a lot of stuff was not only being produced for domestic use in Pakistan, but was being rapidly exported as well. So, you know, there was a silver lining to that, I guess, in the local production of these things, which eventually helped to bring down costs. But as you say, we saw increases of up to 700% in the prices of some items of personal equipment and huge shortages. So that was something that we did find that there was a definite advantage to stockpiling. So with regard to oxygen, we realized that at the peak of the first wave of the pandemic, we would have run out of oxygen in about 9 days of usage. That's all we had. And that's despite the fact that we're a cancer hospital, all our hospital was not seeing COVID. This was a relatively small number of patients in the ICU who were using this. We realized that we would have to double our oxygen storage capacity from 3,000 cubic meters to about 6,000. So that was the second thing that we thought was worth stockpiling. And the third, of course, was medication, drugs. But again, that was a variable sort of thing. With some drugs, such as midazolam, we actually saw a reduction in the price. But some other sedatives and so on that were being used in the ICU to sedate patients for ventilation, such as dexmedetomidine, there were huge increases in price and considerable shortage of drugs. Some antibiotics that were being used, azithromycin and so on, also went up in price and became quite scarce. So we did recommend to the hospital that we consider stockpiling these three groups of items. So we devised a model to look at the items that we should consider stockpiling and how to decide how much to stockpile and so forth. What we did was that we estimated the consumption of these essential items during the reference month, which was June 2021, the peak of the pandemic. We subtracted from that the consumption during the similar month the year prior, so June 2019. And that monthly excess in utilization we divided by 30 to give us the calculated daily use, or the CDU, of that individual item. We added 20% as a sort of buffer and called that the anticipated daily use. And then we multiplied that by the lead time that it took to actually obtain those items. And that varied between about 2 weeks and 6 weeks. So that was the quantity that we calculated would be required to stockpile if the hospital decided to stockpile. You know, you can make an argument in terms of the numbers required and the likely shortages, but obviously there's an economic cost to stockpiling. And it isn't just the financial cost, you also need more storage space in order to stockpile. And that, you know, space for us wasn't really a consideration, but, you know, could well be for other institutions. So that was the model we devised to try and work out what to stockpile and what not to.
And I think, just to pick up on that, it's an extraordinary paper for that, just that sort of thinking, because I think there was a lot of talk about logistic chains, what we should and shouldn't stockpile. But I think, you know, this is clearly one of those areas that cancer services in the future are going to have to think very hard about what they do and don't stockpile, what are critical items. Maybe picking up from that and maybe thinking ahead a little bit here, What do you think the learnings, particularly from this work and from your other work, have been for Pakistan generally? And where do you see things going in the sort of post-pandemic period?
Well, lots of learning, obviously. That we seem to have, as I said, we seem to have fared far better than many others as regards COVID numbers and so on. Even now with the fifth wave, I think that's fairly common across the world now, that there have been large numbers of infections, but very few serious infections and much lower rates of hospitalization and death, thankfully. We've done fairly well in terms of vaccination. We're a country of 220 million people, and we've given about 140 million doses of vaccine. So some of those are second and third doses, some are only first, but nonetheless, we've had fairly good vaccine coverage, particularly in the larger cities. There's been a lot of, as we said, silver linings. We have, in our own institution, and I know in a lot of others, we've started telemedicine clinics, which really were unheard of in our country before. And which are particularly helpful for institutions like ours, because we see patients from all over the country and from Afghanistan. And you'll know as a cancer professional yourself that, you know, often these follow-up visits are literally 10 minutes with the consultant, all's well, I'll see you in 6 months, you know. And to travel 1,000 miles or more to be told that is extremely expensive and must be somewhat annoying for the patient too, I think. And so, you know, telemedicine now constitutes about 25% of all our follow-up appointments. We've done a lot more in terms of day case surgery, in switching to oral chemotherapy regimes where possible, trying to keep patients out of the hospital, and fewer side effects, complications, fewer visits to the emergency room, and so on, all in an effort to reduce patient travel, intermingling of people, and reduce rush and crowding in the hospital. Hyperfractionation of radiation is something, again, we took up initially in breast cancer and in head and neck cancers, but more recently, and I know you'll be aware of this, the work on prostate cancer hyperfractionation. So we've started that too now. And then, you know, the other thing that I mentioned is that a lot more of these things like personal protective equipment are now being manufactured locally. And so actually, we're now paying probably less than we were pre-pandemic for some of these items. So that's been quite a boost for the economy too, I suppose.
That's I mean, this is an extraordinary, as you say, not just an inventory in terms of your stockpile paper, but also the learnings that have come out. And as you picked up, I mean, the learnings which have actually become embedded and now part and parcel of routine management going forward. Well, Asim, look, thank you so much for sparing your time today to talk to eCancer. It's a very quick canter through, but I hope, you know, colleagues and friends watching this will go to the website and actually take a look at this paper and read it in depth. It really is worthwhile. You can't see it very well there, but there it is. It's absolutely superb. Asim's also got many other publications as well, particularly on new therapeutic geographies between Afghanistan and Pakistan. Professor Asim Yusuf, thank you so much for your time today. Really appreciated it, and look forward again to talking to you in the near future. Thank you.
Great. Thank you, Richard. Thank you.